Hey, DeShona.
Hey Marie, how are you?
Hey, DeShona. Are you
Hey
there?
Marie. Yes, I'm here. Can
I
you
don't
hear me?
hear you. Oh, hold on. Are you there?
I'm here. Can you hear me?
I can. Sorry about that. I took my mother to a doctor's appointment this morning and we ended up just getting back.
No,
Um,
I understand.
Complications, but I have a bunch of people waiting in the room, so I'm
Okay.
gonna go ahead and let them in, um, and let you get started as soon as possible. And I
Okay.
do apologize for that.
It's okay. It's okay.
Welcome, welcome. Everybody come on in. Sorry we're getting started late, but we are here and ready to go. Good morning or afternoon, depending on where you are in Tennessee. And I think that gets everybody in the room so far that I can see in the waiting room. Hello, everybody. Welcome to the September Lunch and Learn. We skipped a month here, so it's been a little while, but we appreciate everybody coming. And I am excited for you guys to be introduced to DeShona. I'll let her tell you a little bit about herself, but had the pleasure of working with DeShona earlier this year in one of the, I think it was a tune-up training we did together, and just was really thrilled to get to know her and know that she is in a neighboring state and that she's close by. She has a wealth of experience in treatment and recovery courts to share with you today. If you'll drop your name and email address in the chat so that we can record your attendance. And DeShona, I think I have made you co-host, so you should be able to share your screen. I'll remind you guys that Judge Bull is going to be doing the Magic 3 Minutes in October. So if you are interested in doing that, please register for October and let your judges know too, because the Magic 3 Minutes is specifically for judges. And then I will be quiet and turn it over to DeShona. Thank you, DeShona.
Thank you, Marie, for having me. I'm super excited to be here. Just like Marie said, I work and live in Georgia. I live in Gwinnett County to be exact. Just a little bit about me. We've got a lot of information to cover, and I want to make sure that we get an opportunity to ask questions, engage in discussion, and things like that towards the end. So I'll give a very brief overview of who I am, and then we'll jump right into it. So I am a licensed professional counselor. I worked in accountability courts on the front lines, I say, as a coordinator, case manager, also treatment provider for about 11 years in Metro Atlanta. I love everything treatment court. Another fun fact about me is that I did live and go to school and work in Nashville for 4 years. I absolutely love Tennessee, but Georgia's my home, so I eventually had to make it back. Um, and the last thing I wanted to share is that I have been training with All Rise, now used to be NADCP, for the last 5 years. So, again, welcome everyone. I'm so happy to be here. I do like to use the chat. So, a few things about the chat. Please post your responses, your questions, any resources, any innovative things that you may do in your programs as it relates to the topic, so that others who are paying attention to the chat today can take notes and things like that. So there is going to be at least one activity where you all will you can unmute and share your responses. I'll pull up a Word document. I'll send it to Marie at the end of the training so that you all can have the answers to your responses. I mean, to the questions. Okay, and again, if any of you all have attended the operational tune-up, or if you have received any training or foundational training, you may actually be familiar with this presentation. The presentation has been altered to fit the needs of this particular presentation today, training today. So just be mindful of that. You may have seen this training before, but it is going to be a little bit different, just because there's some things that we wanted to make sure that we focused on today. At some point during the presentation, I will take this presentation off. I'll put a Word document up so that we can do the activity, and then I'll put the presentation back up. We may or may not have time to get through all of it, but it's completely okay. I definitely want to make sure that we at least get through the majority of it. Okay, so we'll go ahead and get started with a team member's guide to effective drug court treatment. Many of you, again, may have been working in the field or treatment court for a while. It is good that we revisit the basics. I just did a training on, back to the basics as a treatment provider, and we just focused on attending, reframing, client-centered approaches to therapy and things like that. And it was extremely refreshing for a lot of treatment providers. So again, you all may be experts in your field, but this is going to be a good review. And then also for some of you who may be new or in another discipline in treatment courts, you may not be familiar. Okay, so big picture. Okay, big picture. So, although we are going to focus a lot on what treatment providers do, we want to also be mindful that um, it takes a team effort, a team approach to make sure that our participants understand that we are treatment court. We don't want to punish. We don't want to send anyone back to prison. We really want to motivate them to be in recovery and maintain abstinence beyond our programs. So we want to make sure that we're using evidence-based and standardized assessments for treatment of their needs. We don't want to use treatment services to reward or punish or serve other non-clinical goals. Treatment providers are trained and supervised to deliver a continuum of evidence-based interventions. There are some programs that do allow treatment providers who are working towards getting their license, but we want to make sure that those treatment providers are supervised by counselor supervisors. And treatment placement, of course, is not based on speculation, gut instinct, or personal discretion. So I get a lot of language sometimes that someone's not motivated for treatment, or they failed in other treatment environments several times and things like that. And we don't want to do that. We want to make sure that the people who we are bringing into our programs have met the clinical requirements, and if they're eligible, that they get into our programs, not based off of if they're motivated. That's not a requirement to get into treatment. We don't want to speculate, oh, I think DeShona is going to make it through treatment or not. We want to use our assessments to deem them appropriate for the program. So the role of the treatment provider on the team. Of course, we want to obtain and maintain consent or release of information, because we're going to be coordinating their clinical care. We're going to talk to their psychiatrists. We're going to talk to other clinicians they may be meeting with on the outside. We may be talking to their medical assistant treatment providers, their family members, their friends, their sponsors. So we want to make sure that we get release of information for all of those individuals and keep them updated. We also provide clinical updates to treatment court team staff at meetings. This has also been a pretty huge topic as I meet different teams in the U.S. And it's pretty consistent. What do we share at staffings? And so I kind of just try to make it pretty plain and simple. Anything that, of course, that is going to impact their participation in the court, in the treatment court. And it does not interfere with the counselor and client relationship. So again, things, surface level things like, she's or DeShona or Jimmy are in a troubled relationship, and this is impacting their treatment. We don't have to go into details necessarily about what has been discussed in one-on-one therapy, or DeShauna's having a difficult time, with X, Y, and Z in the community. But if DeShona has said something to her clinician and she wants it to remain confidential, there's certain ways that we can approach it. So we want to share things that are going to impact treatment, but be mindful that we also want to protect the counselor and client relationship. Educate the treatment court team about what we do, about what's going on with our participants, and things of that nature. And then we also want to make sure that we attend court and staffing. Okay, so, and this is a question that you all do not have to answer, but challenge yourselves to think about this. Does your program offer the full continuum of treatment services and avoid using incarceration to accomplish those clinical objectives? We want to screen, assess, and reassess. The process of screening happens on the front end. You may do your trauma assessment, anger management assessment, substance use disorder screening, and then assessment is going to happen throughout the duration of the program. It's very imperative that the proper screens and assessments are used, so that we are delivering recommendations that's going to place our clients in the proper level of care. It's extremely, extremely important. And that we're also updating our assessments and our screenings to fit our population. I remember in drug court many years ago, we had to implement a reading screening or reading level assessment and screening because, it was the assumption that, most all of our participants could read and comprehend the curriculums and things like that. And we ran into an issue with that. And so we had to implement a reading test in the beginning of the program so that we could adhere to the needs of participants who may have limited comprehension and literacy. So again, screening is the process for evaluating proper presence of substance use disorder. This will happen on the front end. Anyone can do a screening. It doesn't require that you have a license or certification. Anyone can do a screening. And it's just going to, again, test, evaluate for the possible presence of a substance use disorder. Or your trauma assessment is going to check for the presence of a trauma. Does DeShona need to be referred to a trauma group, or or a mental health? We want to be doing mental health assessments on screenings. I'm sorry, on the front end to see if someone needs to be referred to those kind of services. These are some services that are more so catered towards substance use. This is not an exhaustive list, but these are some of the common ones. Some of you may use these screenings in your practices. But again, we want to make sure that the screenings that we use are tailored to our populations. An assessment, as stated before, is an ongoing process, just so that we can diagnose, define the nature of the problem, and develop a treatment recommendations, also known as a treatment plan. These are, again, some of the common assessments that we use in treatment courts, and it's not an exhaustive list. So conducting an effective assessment. Again, some of you may be experts in conducting assessments and screenings. You may have been working in the field for a while, but then there are folks who also may not be as versed. One of it, early in my career before I became licensed, I actually did work in treatment courts. And so I wasn't fully licensed. I wasn't very versed in what treatment courts were looking for in accepting participants in the program. So I had to kind of train my brain to look at things a little differently when I started working with treatment courts. So we want to learn the importance of therapeutic alliance. It's not necessarily just about the assessment. It's doing the treatment plan. Also, you want it to focus on some of the goals that the participants may have. So we want to ask them questions about what they want to work on. Form consensus and collaboration with the client, and also collateral information. So I want you all to also be mindful of the importance of getting information from their previous mental health files. For anyone, I do a bit of contract work now with one of my local accountability courts, and I do assessments. And one of the things that I ask all of my participants is, do you have a history of mental health diagnosis? And if they do, I will request records from some of their previous providers so that I can get some insight into their mental health history. Also, meeting with family, guys, the family will tell you things that the participants won't tell us to kind of help us gain insight into the participants' history and their needs. I've also talked to friends. Of course, I'm not going to talk to all of their friends, but mostly in special cases where the participant may not have a lot of family members or they are living with a friend. I need to know a little bit more insight about that relationship and maybe even how the friend is going to support them through treatment. And then, how many times have we done assessments and the participants told us that they haven't used, and we checked the drug screen history and we realized that they used just before the assessment or they used last week or something like that. So you also want to look at their drug screen results too. That's going to help us do a proper assessment and treatment plan. And of course, this is ASAM's definition of addiction, treatable chronic medical disease involving complex interactions among brain circuits, genetics, and the environment in an individual's life experiences. Remember that our participants on the front end, they are going to continue to use substances oftentimes despite the consequences. So we want to be mindful of that. Keep in mind also that motivation, as hard as it is sometimes to consume that, is not a requirement to enter our program. Okay, the only requirement, of course, are clinical and legal requirements, and that they agree to try the program. So they're going to use despite the consequences. They may stop using for a while and then relapse. That's just kind of part of the process. We don't want to take it personally. We also don't want to take it as, they don't want treatment. They're not interested in treatment. We want to use it as opportunities to adjust what we're doing in our programs. Okay, so let's look at ASAM level of care. Again, remember that some of you all I know are experts already. You already may be very versed with ASAM level of care. So this is a good reminder of why we use it and what we use it for. So ASAM criteria is a reference tool. It contains placement and progression criteria that we'll use following the assessment. So we'll do the assessment first. We'll use the assessment results to determine what level of care our participants are going to fall in. Unless your program has a dual track, okay, high need, high risk track, low risk, low need track, most of our high risk, high need treatment court participants are going to fall in level 2 or up. Okay. So let's take a look really quickly at level 2. So level 2 are going to be our intensive outpatient folks. Okay. They're going to be coming to treatment 9 or more hours a week, or day treatment 20 or more hours a week. Some people may come in at IOP level, and then they may start to use or engage in high risk behaviors and things like that that may require them to be bumped up to level 3 or level 4. That's why we want to continuously assess, continuously screen, so that we are making sure that we're capturing what's going on and not using again, this information, the continued use, the continue using behavior and things like that as a means for punishing our participants. We want to make adjustments, and we'll talk more about adjustments in just a moment. And if you all are not able to see the bottom, I apologize about that. Just looking at level 4, and then of course opioid treatment programs are at the bottom.
We can see it.
Okay, good. Thank you. Okay. And then also, we want to look at our assessments from a multi-dimensional approach. And ASAM uses 6 dimensions, and we want to look at our participants from a holistic lens. And this is a really good tool for service planning because it kind of covers everything. What's their withdrawal potential, some of their health conditions, what's their emotional, behavioral, current statuses and capacities. But do they have any mental health issues? Our drug courts are oftentimes equipped to accept individuals with severe and persistent mental illnesses as long as it does not impact their treatment. A lot of jurisdictions are starting to develop mental health courts. So we want to look at, if a participant is more appropriate for mental health court, or is drug court more appropriate, or can we provide dual diagnosis services for our participants. Readiness to change. Remember, readiness to change has scales, okay? So again, even if someone is in the pre-contemplation stage of change, doesn't mean that they're not ready for treatment, okay? Especially if they say that they want to try the program. It just means that we're going to have to work with those folks in order to build up their readiness to change. What's their relapse potential, continued use? What's the problem potential? What's their environment like? People, places, and things, living situations, and things like that. So we want to look at these dimensions in order to determine their proper level of care. Okay, so again, critical considerations. We want to look at multiple dimensions, cross-dimension considerations. We want to prioritize their treatment based on severity and need, based on individual needs and not program-driven. So we don't want to clump everyone up together. Treatment and accountability courts, we cannot use cookie-cutter approach to adhering to the needs of the participants. We are serving them a disservice if we're putting everyone into the same groups, if we're treating them the same way. So just be mindful of that. We want to make sure, I mentioned this earlier, that they do not receive punitive sanctions or augmented sentence if they fail to respond. If they're treated at a level below the level they are assessed or need. So again, perfect example, bringing someone into the program who needs IOP or who needs inpatient or residential services, and we don't have the services for them, and they start to use as we expect them to, and we want to send them to jail, or we want to terminate them from the program when we didn't have the proper level of care in the beginning. So that's why those assessments are extremely important, and talking with your team and community to see if you have the right services for participants. So this question always comes up. This is always a good discussion. What if I can't provide the level of care needed? Okay. This is always a pretty good discussion because sometimes we have to be creative in our approach with participants if we don't have the proper level of care. We don't want to incarcerate, and I've said that a couple of times, to achieve any clinical objectives, okay? Want to be very mindful of that. Staffing considerations. When we're at staffing, and I know that I've been in staffings where we were talking about one participant for 30 minutes, because we wanted to make sure that, whatever was going on with them, that we heard from everyone. We heard from supervision, we heard from treatment, and that the judge had enough information to deliver whatever recommendation that was coming from the team. So we want to look at who are they in terms of risk. If you've been to again, any foundational or tune-up or even any of the national conferences. I'll also send this if Marie doesn't have access to it. But this is a really good reference tool to use at staffings because it helps us kind of tailor our questions, especially when we have those tough cases. Who are they? Where are they in the program? Why did it happen? Okay, did treatment report that someone was having some relationship issues, that did supervision report that there's no food in the home? What's going on? Do they need an adjustment in their mat services? I remember I had a lady who was she was in phase 1, pretty new to the program, and she would fall asleep a lot in treatment. And I thought it was because she wasn't getting much sleep, doing some things, at night that maybe she wasn't supposed to do. And in checking with her mat provider, they needed to adjust her dosage. So again, if we're just kind of looking at the behavior, not asking these questions, we're serving them a disservice. What's the response? How do we deliver and explain the response to the participants? Because they need to be able to match the response with the behavior. And so responses to behavior, of course, could be a sanction, changes in treatment, or changes to supervision, or all three. Okay. Therapeutic adjustment. So we're going to talk spend a little bit of time on therapeutic adjustments today. They are recommended and delivered by treatment professionals, and your judicial officers. I've heard them be called, case managers or probation officers, surveillance officers. They are going to sanction or recommend the sanctions for participants who fail to comply. Okay. Both the team and the participants need to be able to differentiate between a therapeutic adjustment and a sanction. Okay. We never want to use therapeutic adjustments as a means of sanctioning a participant's behavior. We want to leave that up to our judicial officers, and we're going to talk more about this. So again, therapeutic adjustments, okay? In the initial phases, we're going to be doing a lot of therapeutic adjustments because again, how they present in the beginning, there may be use, there's going to be problematic behavior, there's going to be non-compliance, they're going to resist treatment and things like that. So we're going to be doing a lot of therapeutic adjustments, okay? A lot of times, especially with folks who are duly diagnosed, and they're getting adjusted to medications and things like that. We're going to be doing a lot of adjustments, and then your judicial officers are going to be doing some low magnitude sanctions in order to respond to folks who are in the early phases of treatment to help encourage them to get invested in recovery. And again, I know that we say this a lot, and you probably have heard it a lot if you've been in previous trainings. We don't want to give augmented sentences to punish participants who must be discharged because adequate treatment was not available. So that's why we want to do the adjustments. We want to do proper assessments. We want to use community resources and things like that when we don't have it in-house to help support them as much as possible. Termination, sending them back to jail or prison. We want that to be our last resort, sorry. So treating behavior, okay? Treating behavior. Remember, these recommendations are going to come from the treatment provider. I've heard a lot and just, sitting in staffings myself when I was on a treatment court team and also training various teams, teams will say, well, the judge has recommended that a participant does more MRT groups, or the judge has recommended that the participant meet one-on-one with the treatment professional, or the judge has recommended trauma groups. We want to make sure that it's clear that the recommendation is coming from the clinician, and that, of course, the judge is going to give them the adjustment or whatever sanction in court, but that it's coming from the treatment provider, recommending it to the team, and then of course the judge is going to deliver it to the participant. Okay. Suggested language often is, from the judge, your treatment provider has recommended that you do peer support groups, or going to assess you for trauma specific groups. And the team has decided to deliver whatever sanction, but specifically, the participants in the team need to be able to tie certain behaviors to certain adjustments. Okay. And we'll talk more about more adjustments in just a moment. So, treatment enhancements. So, again, reassessment of clinical needs, reassessment of criminogenic needs, recommendations to trauma specific groups, peer support, move from intensive outpatient treatment to residential treatment. So remember, sometimes participants may come in at IOP, and they may display certain using behaviors that may move them from intensive outpatient to residential treatment or inpatient treatment. That's completely normal, and many of you probably have experienced that. So reductions in treatment, meaning that a participant is progressing in the program and they're ready for less treatment. So remember, we're very top heavy with treatment in the beginning, and then we want to promote autonomy as they move through the program. So we're going to do less treatment. We're going to give them more leeway and things like that, but it's tailored to however they're assessing. Okay. There are some folks who are a little further along in the program, but they kind of still need intensive services, just depending on, just where they are clinically. Okay. Just because someone is in phase 3 doesn't mean that they, have to be attending a specific group, because they may or may not be ready for it. So we just need to be mindful of that. Other examples: fewer treatment groups, decreased one-on-one contacts, or increased focus on vocational employment or volunteerism. Oh, very good. Thank you. Good. All right, very good. All right, so I always like to jump back to the chat from time to time to make sure that you guys don't have any specific questions. Okay, so I'm going to get out of this for just a moment, and I'm going to pull up our activity. Can you all see this okay?
Yes.
Okay. Very good. Thank you. Thank you so much. All right. So finding the appropriate therapeutic adjustments. Okay. So we're going to complete this exercise by making a recommendation for each behavior. So now that we kind of have some ideas, and again, some of you may be pretty versed in making therapeutic adjustments, we're going to just kind of practice amongst one another, making recommendations for behaviors. And also be mindful, I always like to highlight this, that, oftentimes you're going to see that, there's a sanction coming from a judicial officer, and there's some kind of therapeutic adjustment, or there's just a therapeutic adjustment. Okay. And so sometimes that's the recommendation. DeShona, the clinician, needs to work with Jimmy for the next week, do additional one-on-one sessions and things like that. And the judge will say, okay, fine. I'm going to recommend, the team has recommended, a treatment provider has recommended that you work with DeShona in one-on-ones for the next week. And that's intervention. Okay. So sometimes there's the treatment adjustment, that's it, or sometimes you'll see both. Okay. So just be mindful of that. So let's look at the exercise. So during this exercise, you all can unmute and just kind of blurt something out there, and I will write down the response. Okay, type in the response. So the first behavior is failure to attend support group meetings. So if someone can unmute and tell me what's an example therapeutic adjustment that we may make or recommend for this participant.
They would need to add an extra meeting or double the meetings for the following week.
Okay, so recommend additional meeting. Okay, yes. So additional meetings. Okay, Does anyone else have a recommendation? Okay, so recommend an additional meeting. Okay, this may also be a great time to meet with the participant, of course, one-on-one, and talk about why they are not attending the support group meetings. Okay, some participants, I remember, and a lot of us are guilty, but times where we couldn't understand why a new participant, especially, didn't want to attend support group meetings, and a lot of times it's because they've never attended. They're not educated. They don't know what a sponsor is. They don't know even the thought of going to a support group meeting and being in that kind of social setting was scary for them. So this will be a good learning opportunity for a participant too. Okay. What about being dishonest about substance abuse? What would be a good therapeutic adjustment for that behavior? When anyone can unmute.
I would say start over step 1 in MRT.
Oh, very good. Okay, very good. Redo MRT step number 1. Very good. Very good. Very good. Okay. All right. First negative drug screen.
It depends on what phase they're in. If they're just coming in, the punishments aren't great because we expect that.
Okay, so what would you, and thank you for mentioning that. So I believe we said it earlier in the presentation that you're going to do lots of therapeutic adjustments, and there are going to be lower level sanctions in the beginning than someone who's kind of later in the phases who has more skill and more experience in treatment. So thank you. Okay, so if someone is in phase 1, and they achieved or experienced the first negative drug screen, what would be a therapeutic adjustment for them?
Are you saying first negative drug screen?
I'm so sorry about that. Thank you. First positive drug screen. Sorry about that. Thank you.
No, that's okay.
Okay. All right. So first positive drug screen.
If they've already started treatment and they're an outpatient, maybe ask for it to be stepped up to IOP.
Okay, so step up to IOP. So now, are they already in IOP when they first come into the program? So let's just say this scenario is that they are in IOP already, they're in phase 1, they've already started treatment.
So we would send it to the lab, and if it confirms, we would get them into inpatient treatment.
Okay, so, and this is your discipline and treatment provider?
No.
Okay, what's your discipline?
In general, it's a sanction of some sort.
Oh, I'm sorry. What role do you play in the treatment provider? In the treatment court. Sorry about that.
Case manager.
Case manager. Okay. All right. So, and oftentimes case managers are the judicial officers in the court, right? So you're going to be responsible for making recommendations for a sanction, right? So you're going to probably be responsible for recommending confirmation, or the probation officer, and then also making a recommendation for a sanction. Okay, and so that may happen in addition to a therapeutic adjustment. So what could be a good therapeutic adjustment for someone who is in phase 1, this is their first positive drug screen, and we'll just assume that they've already started treatment?
Maybe review relapse prevention.
Okay, very good. What's your discipline?
Case manager.
Okay, very good.
But I was thinking if that, if they admitted use, we go ahead and typically review their relapse prevention plan with them. And if it's later on in a different phase, maybe the IOP or MRT.
Very good, very good. And can someone, and it could be anyone, if we are going to recommend a higher level of care, what's something that we may want to do first before we make that recommendation?
Staffing,
What's that?
meet with the team, discuss it with the
Okay.
team.
So meet with the team, speak with the team, and would it be a good idea to do a reassessment?
Yes,
Yes.
Okay. All right. So we want to reassess. Thank you. We want to reassess and by the treatment provider, and then of course meet with the team. And the treatment provider will make that recommendation. DeShonna's been reassessed. This is what is going on. This is what's contributing potentially to the use. We're going to recommend a higher level of care, i.e., inpatient or residential services or detox services or whatever that looks like. Okay. All right. What about failure to attend recovery support meetings? What would be a therapeutic adjustment for that? This is a repeat, isn't it, guys? All right. Sorry about that. Okay. In a relationship with a known drug user. A therapeutic adjustment for this behavior.
In our court, we typically would increase boundaries at the residential placement homes, maybe a stricter curfew, and certainly meet with their sponsor and talk about all the dangers of that relationship.
Okay. All right. And so, so I like the option for boundaries. I really, really like that. Maybe increase sponsor support. From a clinical perspective, how would you all approach this particular issue? So a judicial officer or case manager, probation officer may say, okay, well, let's, render a curfew. Let's restrict who can come in and out of the house. Let's do a restraining order, something like that. What would a good therapeutic adjustment be? How would the clinician handle this? For any of you clinicians out there, what are your recommendations?
I'm not a clinician, I'm the program coordinator, but we would ask that her case management services be stepped up and increase drug screens.
Okay, so that's a great response from a case manager. Okay, that's a great response. What about the clinicians out there? Okay, DeShonna's in a relationship with a known drug user. Okay, her sanction may be a curfew, or you can't be around this person, or something like that. But what would a therapeutic adjustment be? Any clinicians out there want to take a stab at it?
Add to the treatment plan, interpersonal relationships.
Okay, and who did that response come from?
Angie Duck, I'm still the program coordinator, but that would be something that they could look at.
Okay, very good. Adjust treatment plan. Okay, additional one-on-one session. Okay, so this year alone, I just wanted to share this with you all really quickly. This year alone, we've spent, especially in the operational tune-up trainings that I've done, we've spent a lot of time differentiating between the therapeutic adjustments and the sanctions, because sometimes they do mirror one another. And sometimes it is hard to come up with ideas for therapeutic adjustments. And so that's one of the reasons why I wanted to spend a little bit more time just kind of, brainstorming different ways that we can make those recommendations as treatment providers. And sometimes, again, I've had surveillance officers, case managers, because we all work with participants. They'll say, okay, hey, well, at DeShona, as a treatment provider, have you thought about, meeting with the client one-on-one to kind of find out why they can't stay away from this boyfriend or girlfriend who's using, and DeShona, can receive that feedback, and she can say, yeah, actually, you know what, I can schedule an appointment with them next week for a one-on-one session. So, but it's a challenge sometimes coming up with different ideas on how to, from a clinical perspective, how to address these certain behaviors. But we want to make sure that when a client is struggling with drug use or relationships or some kind of issue that is interfering with their ability to participate in court, that we're making some kind of recommendation for therapeutic adjustment. Okay, how's treatment handling some of these issues in addition to the sanction? Okay, what about quitting their job without informing the court team? For any of you treatment folks out there. Ooh, wait a minute. Okay. I would do a cost benefit analysis with the participant during the individual session. This is great. So if any of you are not familiar, this is a very easy tool that you can do with participants, weighing the pros and cons, looking at, if I continue to do the behavior, where's it going to lead to? If I stop doing the behavior, what's it going to lead to? And it causes the participants to think. Okay, it causes them to think about their behavior and what are the consequences. Okay, so in a treatment team meeting, I love using cost benefit analysis, by the way, but I'll present it to the participant. We'll do it in one-on-one, and then I'll come to treatment court team staffing and I'll say, we did a cost benefit analysis, and although I won't share all of this, I'll say, well, now, DeShona better understands the consequences. And sometimes you can also use that as a conversation piece with the judge. The participant can use that as a conversation piece with the judge in court. Okay, I sat down with my clinician judge, and now I know what the consequences are of my behavior, and this is my plan to not do it again. Okay, so very, very good. Okay, very good. Quit job without informing the team. So we'll just say, we'll just use that for the purposes of time. Okay. All right. And just two more here. Did not complete treatment assignment. What would a therapeutic adjustment be there? Because these things happen and they frustrate us, don't they? They didn't do their treatment assignment, and I don't understand why. And, from a judicial officer perspective or from judge's perspective, it may seem, okay, they don't want treatment, they're not interested, but what would we recommend if someone isn't doing their treatment assessment or adjustment? I'm sorry, their treatment assignments? What will we do in response to that?
I've had that happen, and I had them write a 3-page paper on the consequences of not participating in treatment.
Okay, so that's a good example. Thank you for bringing that up. We can also use essays or apology letter. That's one of those examples of how sometimes that particular thing is used as a sanction. Apology letter is used as a sanction, but it can also be a therapeutic adjustment too, because we definitely use essays. Write an essay, talk to me about what you found in an essay. But in that case, it would not be used as a sanction. It would be used as a therapeutic adjustment if it's coming from the treatment provider. So absolutely, we have used essays in order to encourage participants to think about their behavior. What did you learn from whatever behavior it was? What did you learn from the situation? And kind of write out an essay and process process what happened. Okay. So last one, anger outbursts during a group meeting. I've had this happen before to myself and when I was doing groups, and I've had different treatment providers on court teams also say, well, they had an outburst during group, and we had to kind of process, how to deal with it. It is a rule violation, but it also appear to be an indicator that something else is going on, right? So what kind of recommendation or what kind of therapeutic adjustment would we make as a result of this?
I think that definitely warrants an individual session with the client and maybe get the client out of the room so it doesn't continue to be a situation in a group setting for the other participants.
Absolutely. Okay. Absolutely. So we make an appointment with them, to do a one-on-one session. If in that time it's appropriate, sometimes you just have to schedule an appointment later, but absolutely doing an additional one-on-one session is appropriate. Okay. Very good. Thank you all for participating. So some examples of therapeutic adjustments. Just a reminder, therapeutic adjustments should be based on their treatment regimens and clinical needs. Treatment adjustments should not be used to reward desired behaviors or punish undesired behaviors. That's why we use sanctions and incentives. Okay. So some examples of therapeutic adjustments, and some of you all have mentioned these already. Repeating MRT steps, review and revise relapse prevention plan, increased one-on-one clinical meetings, referral to additional groups, criminal thinking, relapse prevention, trauma, dual diagnosis, CBI, T4C, thinking reports, behavior change, a reassessment. Okay, remember, before we jump the guns and refer them to inpatient or residential services, we want to make sure that we reassess first. Okay, document what's going on with the participants, and the treatment provider needs to make recommendations to the treatment court team. Refer to inpatient or residential services, refer for psychiatric evaluation, watch psychoeducational videos with a written report, recommend recovery and or peer support activities. Okay. So these are just some examples of therapeutic adjustments. It's not exhaustive. There's so many different creative things that we can do in order to support our participants. So I will send this to Marie so that she can distribute this to you all and continue to grow your list. If a person has to be terminated from a program for whatever reason, we want to make sure that we have documented all of our efforts to support them. Okay, so just be mindful of that. Oh, very good. Yes. Process with the group how it feels to be in that environment and let them give feedback, go over the rules with them and remind them of consequences. The person may need to do more individual than groups. They are not yet appropriate for a group setting. So that's something else that I think is also important to be mindful of, that a person may not be ready for group services. And so I've had that happen before. For a second time, not going to tell you guys my million stories, but we've had people who are not ready for a group, and we had to do more individual services with them until they were ready for group. And that's part of good assessment, is assessing them to see if they are ready, for treatment or not. I'm sorry, ready for a group setting or not. Okay. All right. So do participants receive dosage and duration of treatment sufficient to achieve long-term sobriety and recovery? Recovery is a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. And it is not an overnight process at all. It's not an overnight process. Remind your participants as you move forward in the work that we do. I used to get a lot of participants that, they're counting the time. The program is counting the time. They're like, you're in phase 3, and you've got 8 more months to graduate. And that's not necessarily how we want to approach, because they're in phase 3, but their time may be extended because of different behaviors, and maybe they're not responding to treatment, or something else is going on. So remember that it is a process. It's not an overnight process. It's a process of change for participants to improve their health and wellness. Okay, so treatment dosage, best results if treatment lasts 9 to 12 months. Our high-risk, high-need participants are going to receive about 6 to 10 hours of counseling weekly in the initial phase, and 200 hours of counseling over the course of treatment. Most effective programs, we are flexible. Okay, we want to accommodate individual differences of our participants. Approaches to counseling includes a clinical and criminogenic piece, okay? And then also facilitated by clinicians that are culturally competent, okay? This is not an either or situation, it's a combination. We want supervision and services in our treatment courts, okay? Both are equally important. Okay, and it results in significant increase to public safety and huge cost savings to our communities. And again, if you all have attended our treatment court trainings and things like that, you've heard of this a lot. Treating high risk, high and low risk offender together is harmful. Treating people with and without substance use disorders together is harmful, as well as requiring a person without a substance use disorder to attend recovery support groups. It reduces treatment effectiveness. But we don't have participants in our program who don't have substance use disorders, in treatment courts, especially if that's the population that we're serving, that we're doing assessments on the front end, that we are really capturing folks with moderate to high substance use disorder and high risk, high needs. Ask yourself, does your program offer regular individual clinical sessions? Are they screened? Like Marie mentioned earlier, are they screened to determine suitability for group interventions? And so we want to make sure that we are screening them for group suitability. If not, we are doing them some disservice. If they are not suitable for group, we're going to have to be heavy on individual interventions. Look at a smaller group setting, maybe look at some groups that are more tailored to their needs. I know at one point we had a co-occurring group track, especially because we didn't have access to a mental health court. And so those participants had special needs. So we had to create a separate track for them so that they can get the most out of their treatment. Group treatment is effective and provides the most benefit to our participants. At least one individual session in first phase of treatment. It could be more. And then making sure that we are using evidence-based treatment based on their needs, gender, trauma histories, psychiatric symptoms. And this is, don't fuss me out, okay? It's best practices, but I know that it doesn't always happen this way, but no more than 12 participants and 2 facilitators in a group. It's just, a suggestion. I know that this isn't always realistic for our various programs. And then are we, as providers, proficient in delivering appropriate evidence-based treatment interventions? And making sure that we continue to educate ourselves, that we invest in training. There's a lot of training that's on the All Rise website. Now there's on-demand training. And a lot of, I know that you all don't have a lot of time, but when you do have time, just kind of becoming versed with best practice standards, because it helps a lot in the day-to-day work that we do. And so the more that you can familiarize yourself with best practice standards, the better. Treatment core outcomes improve when we, of course, utilize behavior or cognitive behavioral interventions, that we carefully document the interventions and treatment manuals, that we're licensed or certified, that we're trained, and stick to the fidelity of the treatment model. So if your various programs have clinical supervisors, and I know sometimes coordinators also kind of do some oversight with treatment, that they are, meeting regularly with treatment providers to make sure that they are adhering to best practice standards when delivering treatment. And so ensure, as practitioners or coordinators, that you are versed in what treatment's doing, that you're asking questions, and also if there's any opportunities for continued training, especially in treatment modalities, that your program is investing in training your providers. Okay. Components of comprehensive treatment. Again, we want to make sure that if we can't offer all of these treatment services in our particular program, that we are tapping into community resources, okay? Child care services, family services, legal services, all of those different services. We want to make sure that we are able to offer our participants, because they have so many different needs. We talked about client-centered services, okay? All right, making sure that we're asking them what they want to work on, and that whatever their risk assessment says or clinical assessment says, that we are tailoring the services to their goals. Okay, many of us are familiar with medically assisted treatment, okay? We want to follow the doctor's order. Okay, we know that medical assistant treatment options improves outcomes. Okay, these are some examples of some of the medical assisted treatment. If they are prescribed psychiatric medications, or medications for chronic pain, or medication for opioid use disorder, or alcohol use disorder, whatever that looks like, that we are following the doctor's orders, okay? That there's someone who is overseeing. I know a lot of times it's case managers, but we want to make sure that there's a release of information that we have in place, so that we can talk to those providers to make sure that participants are adhering to the medication. They're taking them as prescribed. And if we see things on our end, because we're doing the day-to-day work with them, that we report them to those providers, okay? These are some examples for medications that some of our participants may take, again, for alcohol use, opioid use disorder, or other medications that participants may need to receive medical assistant treatment for. Okay. Follow the medication policy of your program according to best practice standards. Be mindful that in your handbook, your policy and procedure manual, that you want to make sure that you provide a policy for medical assistant treatment. Or if a person is coming in, they're taking psychiatric medication or pain medication, what's the policy for that? Okay. Follow the policy of your program, follow your statewide rules and guidelines. But we want to follow the doctor's order, okay, for medical, substance abuse, mental health issues, and make sure that we have the proper release of information on file. Okay, and we are finishing up, okay. Sometimes we do have to have more than one or two treatment agencies that are responsible for managing treatment services, and we want to make sure that we have a good line of communication, okay, if there is more than one or two, and that they can attend, some kind of representative from that agency is able to attend court and staffing, so that everyone knows what's going on, everyone's on the same page, about what's going on with those treatment providers and your participants, okay? And making sure that they have experience with criminal justice populations. Because remember my story in the beginning, when I first started working with treatment courts, I did not have the ear and eyes to do the assessments for our population. So I had to learn how to tailor my assessments and treatment services to cater to the needs of our treatment court participants, okay? Because they are a special population. Okay, know your treatment provider. In a team that I recently worked with and did a foundational training, that means that they were starting up brand new treatment program. They just thought that this particular tool was the greatest thing since sliced bread. Okay, and again, because they were looking for qualified treatment providers to join their program and deliver services to their participants. So this particular tool or reference tool is going to ask those questions that you need and also create your MOU for your treatment provider, okay? This tool is offered on the All Rise website. And so another thing, again, if you're interested in this, or if this is something that you need, Marie and I both have access to it, so we will be happy to send it to you. All right, let me make sure I didn't miss anything in chat. Okay. All right. Okay, requires
I've been
participants.
putting a lot of stuff in there, as you see.
Good. Thank you so much. Yes. No one in here has had 20 people in a group. I have. Okay. But, definitely not fun. But thank you for doing that. So questions. Does anyone have any questions? And I want to stop sharing so that I can actually see you all. If you all have any questions, any resources that you all need, I'd be happy to send them to you, or take a few minutes to answer any questions that you all have. Okay, very good. Thank you all for your attentiveness and your participation today. I hope that it was for some of you all, a refresher. For some of you all, good information for you starting off in the accountability court program. And the biggest takeaway today is, of course, it's a collective effort, okay? Although a lot of this was addressed towards treatment providers, we all, no matter what discipline you're in, we want to be versed in treatment services so that we're all speaking the same language to our participants. And thank you.
Thank you so much, DeShona. Appreciate it. Thank you, everybody. Have a great rest of your day. It's good to see your faces or your names. You'll get an evaluation soon so that you can complete that and get your certificate, okay?
Thank you.
Bye.
Thank you all. Bye.
I'll see you tomorrow, Sharita. Looking forward to it. I'm so excited for you guys.